Richa, Thambu, my dear friends. Tuberculosis is actually the worst, the most serious infectious disease in India. But we know so little about the epidemiology of tuberculosis. We clinical TB very frequently, but so I'm taking you into the epidemiology of TB with lessons for clinical practice, lessons for public health or control of TB is another interpretation of the same data that I'm going to present, which is the national cluster sample based, microbiologically confirmed pulmonary TB prevalence survey conducted by ICMR in 2019 to 2021. On 13th of March 2018, inaugurating the United Nations Global End TB Conference in New Delhi, our Prime Minister declared intention to make India TB free by 2025, that's next year. 5 years ahead of the UN goal, which is 2030. Richa mentioned about my involvement in TB. I was an invited participant in that meeting. So there I have of being a student of TB for a long time. The revised National Tuberculosis Control Program renamed itself as National TB Elimination Program. That's about all that has happened in the last so many years. In 2019, ICMR conducted a national TB sample survey for defining the baseline. Look at that. We don't have a baseline. We have a goal of elimination. We have been controlling TB for since 1960s, revised in 1990s, yet we don't have a baseline. It was a well-designed, well-conducted study using cluster sampling methodology. India was divided into a grid of 20 units. Major states, 1 unit. Smaller states may be clustered. So there will be a northwest cluster and a northeast cluster, but Tamil Nadu will be 1 unit. 625 clusters of 800 persons, 15 and above were selected, of which only 443 need to participate or eligible to participate. They were surveyed. Sample of 322,480 were actually the subjects of the survey. All had symptom screening by questionnaire and a chest X-ray in a mobile unit. 13% were eligible for microbiological testing, of which 981 were proven positive. Okay, and they were referred to the RNTCP, NTEP for treatment. So these are the clusters that they surveyed, fairly evenly distributed throughout the country. The symptoms used for screening were cough and fever 2 weeks or more, which is the standard RNTCP requirement. Blood in sputum anytime in the past 6 months. Chest pain anytime in the past 1 month. Loss of body weight. In the result section, 3 more symptoms are inserted in. So I guess they were in the questionnaire: night sweats, expectoration, loss of appetite. The microbiological methods were symptoms from those with chest or other symptoms, or abnormal chest X-ray reading. How do you collect sputum from normal people. So they asked them to sort of cough and produce as best as possible whatever comes in the throat. So it's a throat sample, a throat secretion sample. The first sputum was tested for cartridge-based nucleic acid amplification test right in the mobile unit. The second sputum was used for smear and liquid culture. So that was mandatory. Everybody had first and second. First on day 1, second on day 2. If the first was positive, a third sputum was collected for all 3 tests. That is smear, liquid culture, and TB-NAT. This is the prevalence of microbiologically confirmed pulmonary TB in all the 20 clusters. You see, it's a wide variation. The national 316, 290 to 342, the 95% confidence interval. 4-5 states, Delhi, Rajasthan, Uttar Pradesh, Haryana, Chhattisgarh are in the high range, about 400. Kerala, Gujarat, Maharashtra, West Bengal, 4 at the lowest range. There are 11 below the national mean. 9 of those are sea coastal states. That's very interesting. Whether it has any meaning or not, we do not know. Only Punjab and one more in that group are landlocked. The point prevalence of 316, 290, 342 is an underestimate of annual incidence. Obviously, point prevalence is on the day when you test it. Annual incidence is what occurs throughout the year. So we don't know how much for annual incidence, you could add 50% more and you reach 400 level. The NTEP's 2023 report recorded 172 reported pulmonary TB cases per 100,000 in that year. Extrapulmonary TB, pediatric TB are not represented in any of these counts. So when you say TB, everybody means pulmonary TB because it's easily diagnosed. There is a, you can sample, the relevant body fluid, whereas the others you don't. When X-ray was read first locally, then experts, if 2 experts, independent experts sitting somewhere far away, suggested that this lesion abnormal, the X-ray is abnormal and has TB-like lesions, but the microbiological tests were negative, they were classified as clinically diagnosed pulmonary TB. There were 4,478 subjects, all referred to NTEP for treatment, but nobody knows how many of them were actually confirmed by NTEP as TB and treated. It would be 1,388 per 100,000 per 100,000. So if you add together 1,704 per lakh, cannot be true. So some of the clinically diagnosed are false positive, or do they self-heal? You have X-ray lesions and do they heal by themselves? We don't know. Again, just eyeball this range. Infectious disease specialists like me have a rule of thumb. Prior to control by intervention, all respiratory transmitted infectious diseases show fairly uniform prevalence in all regions within a country because social contact movements are unrestricted within the country. Across the border, you have restrictions. Say COVID, flu, measles, rubella, varicella, poliomyelitis, diphtheria, pertussis, all of these are respiratory transmitted and have a uniform prevalence throughout the country. Why does pulmonary TB not follow that rule of thumb? It's not population density, because Kerala and West Bengal are among the 4 high density states. They come under the lowest 4 states in prevalence. So it is not simply population density. That is the immediate thought that comes to you. MTB is necessary, but not sufficient for pulmonary TB. There is a constellation of causes. So TB is like one non-communicable disease, although it is a communicable disease. What is non-communicable disease? You have it, but you don't know you have it, but doctors have tests to detect it. The chronicity, if left alone, chances of high life-curtailing complications are very high. So should we be routinely screening every adult? That's a question for you, irrespective of what they come to the hospital for. Okay, the age spread. You see, from about 200 per 100,000, it has a fairly steady increase up to nearly 1,000 according to the age group. 15 to 24 first, 25 to 34, 35 to 44, 45 to 54, 55 to 64, 65 and above. The upper line is men, the lower line women. Interestingly, look at the 15 to 24 points. If you project them backwards to birth, starting at 0, you can imagine that the 2 lines hug each other fairly closely up to 1524. And the rate is 0.2%. That is, it's a steady increase by age. And then beyond 24, we branch off, men along one path, women along another path. Immediate question is it a sampling error? No. Sample was more or less equal men and women. In fact, a few more women than men. There is something very interesting in this. I'll come to that later. The report had risk factors associated with TB, and their risk factors are not truly risk factors. It's a mishmash of 45% were employed people. Is employment a risk factor for TB? Probably not. Far more men, if you look at the employment picture of India, far more men are employed than women. So it's an artifact. Down the line, low BMI, smoking, alcohol, diabetes, a low body mass index, past history of TB. These are all valid risk factors. And the one outlying thing is abnormal X-ray. It's truly not a risk factor, but it is a signal, early signal to diagnose TB. When they plotted subjects with past history of TB, very interesting picture. Again, look at 15 to 24. It's the same. So past history of TB in up to the adolescent, young adult age period, boys and girls behave similarly, and then they branch off. Okay, and it's a steady increase in men, and not so steady in women. A smaller sample was collected during the survey for interferon G release assay for finding out how many are latent TB, and men and women increase up to about 45 to 54, and then men flatten off, men decline. So that tells you that the IGRA also is not an ideal tool to look at your past experience with M. tuberculosis infection. But that's the best we have. Is there a fall-off? People who were positive at one time, according to the previous slide, do not seem to have the same tempo. 43% had no symptoms but picked up just by X-ray. So the risk factors, gender, male, why? That is a researchable question that needs to be researched. There are many differences between men and women, hormonal maybe. So that is a researchable question. Age 45 years and above, immune senescence, too early. Or longer exposure, longer risk period, we don't know what. Reinfection, past history of TB, immunity is non-protective. That we already knew. BMI, low BMI, it could be a cause in the cause constellation, or it could be an effect. You have to dissect them out. Diabetes mellitus, don't all adults deserve diabetes screening also? Smoking, education must start very young. Alcohol use, education must start very young. Employed, I already talked about men overrepresented, but there is a lesson here. Employed people are captive population. So if you want to screen, you can start with employed people. They're available year after year. Importance of routine screening and of NAT. 88% of people who we are calling cases were not aware they had TB. That's to be, normal. 69% were not sick enough to even seek healthcare. That's very interesting. 43% were picked up only by X-ray, 42% confirmed by smear, 25% smear negative liquid culture positive, 33% smear negative NAT positive. So ultimately 33% could be NAT. There's a lesson there also. Definition of pulmonary TB. If you have no symptoms, but your throat liquid called sputum shows MTB by NAT, will you call it pulmonary TB? Or is it subclinical TB? Or is this the earliest signal of reactivation of latent TB? In other words, preclinical TB? We just don't know unless they are followed up. I tried to get the researchers to at least catch some of this for follow-up. No way. Will all of these progress to pulmonary TB disease? Will some self-heal, stop shedding? We do not know. In my first title, I referred to the Rotary Club of Vellore TB control project, which is a joint project with Rotary and CMC. We support very poor persons with TB. DOTS program staff identify them and they refer to us. Our staff visit families regularly, once a fortnight, and I visit whenever needed. And counseling is given. So there is a human contact with a non-TB system every 2 weeks, systematically, which is a step towards making them take the full treatment. They have problems in the first month with drugs, but somebody has to hold their hands and say, it's okay, we'll be, so that's part of the deal. The other thing is we give them generous food supply. We started with the first patient, giving the patient alone nutritious food. No way, families won't accept it. So we give the entire family reasonably good nutritional supply. The then health minister in Delhi, when he heard about all this, he then decided to give 500 rupees per every TB patient and also nutritional support by Nikshay Mitra. It's more recent. About 60% of our clientele did not start with cough and sputum. The classical symptoms they teach us should deserve testing and symptoms. Non-pulmonary symptoms misguide the first contact doctors and delay the sputum testing by 1 month, 3 months, 6 months. All right. So all of them are infectious. No symptoms, no pulmonary symptoms. Pulmonary symptoms. Medical fraternity must be retrained for early diagnosis. That's one of my reasons for addressing this audience. Just a revisit of that range. Epidemiologically, India is not one unit. So one size fits all principle is not valid. Every state and union territory must be considered as a separate denominator. They're trying to control TB without understanding its epidemiology. Treating TB, you don't need to know epidemiology, but controlling TB is impossible if you do not understand the epidemiology. How well do we know TB epidemiology? In children, we know there is progressive primary TB, which is relatively short incubation period. 1 year, 2 years, max 3 years probably. Adults have long incubation period, decades. This is classified as latent TB, moving on to reactivation TB. Long incubation period. Infection in the non-immune, because only 40–50% are latent TB, the rest of them are non-immune. So their first infection TB, are they not more like progressive primary TB in children, even though this is in adults? Infection in already immune, reinfection pulmonary tuberculosis. So these are, we mix them all up and say pulmonary TB. So putting all this together on a very simplistic diagrammatic presentation, you take the pool of latent TB. In India, probably there are 500 million, this number picked up. From them arise reactivation TB, extrapulmonary TB, we lose from the TB control program because they are dead-end infections, transmitted to anybody else. We don't even count. So I assume that almost all extrapulmonary TB comes out of the pool of latent TB. That's an assumption. Then reactivation TB is a fairly large circle. Sorry, reactivation TB is that one. Reactivation TB, pulmonary TB, sheds mycobacteria into the atmosphere, and so non-immune people get first infection, immune people get reinfection. Okay, first infection, reinfection. Once they get disease, the first infection disease is marked, especially I'll tell you why. They are actually driving the in these three groups: reactivation TB, reinfection TB, and progressive primary TB, children and adults. Now, in developed countries where TB has been controlled drastically to extremely low levels, they don't have any pool of latent TB. So it is first infection TB, progressive primary TB, back to first infection. So that's the cycle. That's the only cycle they have in developed countries. There, if you diagnose and treat TB early, the cycle can be cut. So in many developed countries, rich countries, the rate is in the range of 3 to 5 per 100,000 per year. But every case of TB is given so much of importance that they cut further transmission lines. Their TB is mostly in migrants. However, for them, the approach of early diagnosis and treatment is perfectly good for controlling their TB. It's of no use trying to control TB in a country with so much of latent TB. What are their proportions and age distributions? Reactivation TB. Do we know who are the reactivation TBs when they come to our clinic and we diagnose them on TB and put them on treatment? As I said, dots alone will not control TB in the country. First infection TB, that is the rich country model. Dots alone will control in low burden countries, not in high burden countries. There it's not dots, there it is the usual textbook treatment. Reinfection TB, dots alone will not control because this reinfection is the signal that we have a lot of backlog of TB. So you cannot control TB just by preventing infection from them alone. So we have long ways to go in TB control. DOTS actually was an Indian design for effective treatment in the 1950s. DOTS was designed for effective treatment, domiciliary treatment, instead of admitting them into sanatoria. Foreign experts who designed RNTCP were familiar with their TB epidemiology. All first infection TB, low burden, 3 to 5 per 100,000 per year. Early detection and treatment cuts transmission. They did not factor in the pool of latent TB. Without shrinking of wage, control is impossible in India. Foolishly, we adopted it without even applying our mind. You've seen this slide earlier, the association of age with pulmonary TB, men and women. Just keep that in mind. This is how many of them are getting treated. You can see that from about retirable age beyond 55, they're lost to the system. Imagine a family with an old man or woman having any of this, coughing away, fever. The tendency is to take your own time to take the person because it will cost money. So their treatment rate is way down. The same phenomenon for women also. Beyond 35, 44, women are also kind of neglected from healthcare system, and so their TB is not necessarily diagnosed. We must hang our heads in shame. The huge TB burden in the third decade of 21st century is unacceptable. It should be unacceptable. The developed countries, all of them have public health division, independent of healthcare management. And they also have universal primary healthcare, also secondary healthcare. Without these two, I do not believe TB can be controlled. What is control? Bringing from 300 to 10 per 100,000 per year. Definition of global definition of TB under control. What is TB elimination? Less than 1 per 100,000 per year. Our baseline is so bad that when can we ever hope to control or eliminate TB? The survey has illustrated problems of diagnosis and the very complex epidemiology between reactivation TB, first infection TB, and reinfection TB. Are histories of symptoms the same or are they different? Are clinical presentations the same or are they different? How about chest X-ray findings? These answers are likely to help us to diagnose TB very early, avoiding weeks and months of delay as it is as of now. Are drug sensitivity profiles different in these three groups? So doing NAT in the first sample gave us a handle on the rifampicin resistance pattern, and 0.6% of them were rifampicin resistant, but the survey kind of ignored it, saying that the vast majority are sensitive, and therefore unlikely to be MDR. But we do not know exactly. MDR is important for the person with MDR, but epidemiologically, MDR is not a major issue as of now, unless this sample survey somehow undercounted the MDR TBs. Thank you very much.